The coronavirus disease, referred to as the 2019 novel coronavirus, shortened to COVID. How? Corona, virus, disease, making COVID. Its origin, Wuhan, China. Its destination, all over the world. Flight time, rapid. Here we are today with a list of vaccines manufactured in less than 18 months. Are they safe? Are they effective? Now the conspiracy theorists are watching this unfold, asking themselves, remember when Bill Gates created Microsoft, then created viruses to attack your machines, then charged you money to buy antiviruses? A story for another day. Globally, there are over 120 million COVID-19 cases, over 2.6 million deaths, and over 68 million recoveries. In Zimbabwe, we have over 34,000 cases, over 29,000 recoveries, and just over 1,300 deaths. Now, we know those relatives and colleagues who say, come on guys, COVID haimo Zimbabwe, and this disease hasn't hit us hard. Let's be careful here. See, the danger is COVID-19 is still here, and scientists warn us that it is here to stay. In fact, April in Zimbabwe may usher in a brand new wave, the third wave. This means more infections, possibly more deaths, and more un-Zimbabwean contactless burials with no closure and no emotional support. COVID-19 has been so abnormal for all of us, or were we all abnormal all along, and now we've been normalized? Zimbabwe introduced Sinopharm, a COVID-19 vaccine manufactured in China. Is it safe? Yes. It uses old and trusted technologies which most health practitioners and scientists will tell you is something we can rely upon. The screen you're watching this on was likely manufactured in China. The device components too. The clothes you're wearing, branded or without a totem, were as well likely made in China. The fridge you opened just now, the car parts you bought last month, the kettle that boiled the water for your coffee, the hair on your head. Look, let me stop there. Then you wish to question a vaccine that's made in China. Interesting.
So I know that many are worried about, has this been tested appropriately? Does it work in our population? The scientific community within Zimbabwe, which I'm a part of, has reviewed the data. We've communicated with colleagues across the world, and some of you may have seen even the New York Times had a commentary about it. The Sinopharm vaccine is a genuinely made vaccine. It's safe and it's effective. It has been tested appropriately in more than 30, 40 countries as we speak now. So I think the hesitancy and the fear, while I understand where it comes from, is probably a little bit misplaced based on what we know scientifically now. I would say that given how scarce vaccines are across the world, when your turn comes, the first thing you should do is try and make an effort to get the vaccine.
Sure.
You want a Novavax vaccine, you want an old technology vaccine, of which Sinopharm is one.
Of those,
okay? Yeah. What I would be very nervous of, because of, and I mean, we see a lot of stuff that the public don't.
Right.
There were 600 children that died in one country that was given mRNA vaccines 4 years ago. So I'm very, very nervous of the new technology. Don't look at the efficacy. There's not a single vaccine.
That's 100%.
No, but you don't want 100%.
Yeah.
Because that's huge amounts of immunity. You want a vaccine where you don't die and you don't go to ICU.
Yeah.
I don't care if I get a cold. All of them do that. So go for something that's safe. Johnson & Johnson is one dose. They can't mess up the cold chain. And you won't think of these kind of things, whereas we
don't.
do.
And all we look at is this efficacy, because that's also what you highlight as medical fraternity.
No, it's what the media highlights.
Okay.
Not what we highlight.
All right,
it's the last
so
thing I'm
remove me as
interested
the
in.
media right now and speak as a doctor, right? Okay. When we talk about why and which vaccine is the best, what do you judge with?
You judge for the best vaccine for the individual, okay?
Right.
And if I'm looking at an African scenario,
right,
I'm worried about the cold chain. What's the point of vaccinating with a vaccine that the cold chain's been broken? It's going to be ineffective.
Right.
So let's get in one that doesn't need a cold chain, J&J. I want a vaccine that stops people from dying and going to ICU. I don't care if they get colds. First world problem.
Yeah.
You know what I mean? And that's all it is. So let's start looking at, for Africa, what do we want? One dose. It's much easier.
Yes.
Especially with rural areas.
Yeah.
We want something where we don't need a cold chain.
Yeah.
Okay. We want something that treats the South African strain at the moment. We want something where you don't die or go to ICU. Johnson & Johnson fits all those criteria.
Interesting. Our neighbours in South Africa are getting vaccinated with the Johnson & Johnson vaccine, a popular one on the global market, with an efficacy of 72%. You only need one dose of it, and there's no need for a cold chain. While in the UK, it is said that up to 200 deaths are occurring per week as a result of the Pfizer vaccine. Now, do you see where this is going? Sinopharm has killed no one, not a single death recorded to our knowledge since the recording of this show. Here's a list of the vaccines by efficacy: Novavax, Pfizer, Moderna, Sputnik, AstraZeneca, Bharat Biotech, Sinopharm, Johnson & Johnson, and Sinovac. Is the public sector prepared for this third wave, do you think?
It's more prepared than it was for the second wave, but still not adequately prepared in my opinion. And I think then we really need to consider, especially the issues around human resources. It's good to have facilities that have equipment and things, but you need human resources, and you need human resources that are motivated, that are trained adequately, and who can do the job on the ground.
Let's troubleshoot. How do we motivate? How do we train?
So training, I know there's been training that's been happening all through, and training is an ongoing thing. With new information, we disseminate guidelines, we train people on how to do things, case management, and that's been going on. Motivation, simple answer, people. The reason why everyone gets up and goes to work is for money. Pay the healthcare workers adequately so that they're motivated to keep doing the job that they're trained to do.
So salaries need to go up.
Absolutely.
That's a hands down.
Absolutely.
You support it, you agree
Absolutely.
with that. So in the absence of that, there's the private facilities. Chiremba murkudura. Who can afford one, private services, right? A doctor coming home, who can afford the private facilities? If you don't have $1,500 or $2,500 or up to $5,000 to pay that deposit for your patient, what do you do?
It is very difficult. And I once again I say that public facilities in Zimbabwe, traditionally 85 to 90% of Zimbabwean population uses the public facilities. Yeah, and the private facilities are really just for that 10-15% who say, well, I think I would rather do a private facility. So private facilities should not be the go-to. They should not be the first port of call for the population.
But right now they are. You agree that in the first and second wave, the private facilities were the first port of call.
Yeah.
Because ndo kune ma facilities, ndo kune mshonga, ndo kune ma ventilator. Saka apa third wave apa tichakwanisa here kuenda ku public facility.
That's what we need to push. We need to push. We need to work for that. Where I should feel confident and comfortable knowing that if I get sick, if my neighbor gets sick, my local hospital is Paringatwa, my local hospital is Salim Gabe, Chitungwiza, I can go there and get quality care. The medication, the interventions that are required are available.
Now, Zimbabweans blamed South Africa for our second wave, which came in around in December, January, and they called it the South African strain. Now, fully aware that there's different strains, it's a mutating virus. I don't know if it's in defense of your country, but maybe just a little bit of education on that, because socially it does become a thing where Zimbabweans just say, no, if it wasn't for the borders opening in December and all that movement, we wouldn't have gotten the second wave. How do you see this as a health professional?
Okay, well, if you look at a pandemic, from what I understand, has 3 waves. Yeah. So you're going to get them whenever they come. The biggest problem with the new variants in South Africa is they can infect you twice. So that could have contributed to a worse wave than what you'd expect. And I already know a few doctors who have had it twice. Yeah. So that could have contributed to a worse wave than what you would have had. And I think the Zimbabweans must blame themselves. They came home, didn't they?
Do you think that this is the best possible vaccine for our people?
I can't answer that question because in fact, no one on planet Earth can answer that question because all these vaccines are new. Mm-hmm. We will only know when we have vaccinated millions and millions of people and we begin now to compare and see which population is better protection than the other.
So you feel
as far as Sinopharm is concerned, I have no problems with it.
Have you taken it? Have you taken it?
Yes, I was vaccinated. I'm waiting for my second dose.
Good. Okay.
I have no problems with the technology used to manufacture it and so forth. I have no problems with the studies that have been published by other countries like the UAE and so forth who have used it. But that information the general public does not have. I had to read that for myself in scientific journals, and not everybody reads scientific journals.
True.
We hope that this show will answer all questions and allay all fears around the COVID-19 vaccine in Zimbabwe. Sinopharm that is being rolled out here is what we need to focus on. Before we get to the vaccine, however, we must still remember the basics. PPE, capacity of public and private healthcare facilities, job satisfaction of public healthcare workers, and of course, how to prepare, prevent, or manage the anticipated third wave.
Okay, so in terms of from a preventative perspective, obviously vaccination is one of the key elements of that. To be honest, we're not going to have achieved sufficient vaccination cover in Zim to fight the third wave using vaccination alone. So we go back to our standard public health messaging. Social distancing, avoid large crowds, wear your mask.
So when does the average Zimbabwean get the chance to get vaccinated?
So I suppose there are two things here.
Yeah.
If it were entirely up to the government, I think by now most of us probably would have the vaccine. We don't have nearly as much vaccine as we have people who need it. So they're trying to ration fundamentally a globally scarce resource. Projections are probably from the beginning of April. We may be starting to roll it out on a much more wider public basis in the phase 2 groups.
And will we pay?
It's going to be free. The initial intention is that it must be free for everybody, but because we realize the capacity is limited, the private sector has been encouraged, and some of them are coming on board. So I think employers can, working with the government through the National Vaccine Procurement Fund, contribute, and that's going to help substantially. We also have some vaccines that are supposed to come through the World Health Organization, through the COVAX facility. That should also be free.
Now let's talk about the healthcare workers, right? I believe we are preparing for a third wave in Israel.
Correct.
And you're certain, is this imminent?
It's always hard to say with certainty. But if you look at what's happened, once you relax restrictions and people begin to interact a bit more, logically speaking, as long as there's any infection going around, it cascades a little bit more. And I think we're headed towards Easter. That's always a bit of a concern. School kids are going back to school. So I would be very surprised if we didn't see an uptick in cases over the next 3 to 4 weeks. I think.
How do we stop this? No one wants to hear that. Do you know what I mean? But at the same time, everyone's tired of being locked up. The kids are going back to school. Easter holiday, that's kumusha. Which one kumusha? Because right. Is that accurate, by the way, or is this a myth?
So it's fair to say that most cases initially were imported, so they predominantly ended in the urban metropolitan areas. Yeah. But I think there's now a decent amount of community transmission, even in the somewhat remote areas that even without us traveling there, there is some low-level transmission going on.
So it's everywhere now?
It is pretty much everywhere. I think if you look at the national statistics, it's still bigger because the big cities have more interaction, but even in the villages we have community transmission. We wish we could completely eliminate it, but I think it's a delicate balance. I'm hoping the third wave will probably not be as bad as what we had with the second wave.
Are you ready?
Healthcare-wise?
Yes.
You mean
and the country and facilities, are we ready?
We are much better prepared than we were last time. I think we learned a lot about how to deliver better care last time. I'm hoping we will be when the time comes.
And ready beyond having $2,000 for a bed in a private facility. I mean, ready, I can walk into Harare Hospital, Mpilo, and get the service that I require if I am a COVID patient.
If that's the level of readiness that we want, then I think we are certainly not quite there yet.
Which public hospitals would you say are remotely able to accommodate?
Pari has had the best capacity within the greater Harare area because they've got a dedicated COVID unit, which is decently staffed and has the capacity and facilities.
As long as we have any new cases, as long as we have any cases, there is a possibility of having a third wave. It's just that simple. But if people do what they're supposed to do, i.e. social distance, wearing their masks and washing their hands with soap and running water and all that, if you have the disease, then you're not able to pass it on, then there's no way you will have a third wave if the transmission is not going to continue.
Cost of treatment in Zimbabwe. It costs thousands to get a private bed, with deposits starting from $2,500. But sadly, no amount of money, power, connections, or influence can save one's life at a certain stage. In the past 12 months in Zimbabwe, we have lost cabinet ministers, generals, artists, and loved ones. With the second batch of deliveries from China of the Sinopharm vaccine, our president, His Excellency Emmerson Mnangagwa, received his vaccination, I guess the first round of his COVID-19 vaccine. In January of 2021 alone, it was scary to open our phones in the morning, unsure of who had succumbed to this cruel and relentless virus. While our statistics did rise from December to January, they still remained relatively low compared to other African states. Now, what alarmed us most was the whom was dying.
Question. So the first thing is that the virus does not select. It is an airborne virus. It will not select. If you're in the right place, or maybe go the wrong place at the wrong time, and you don't take adequate preventative measures, you will get sick. Now, one of the other challenges that we face, particularly here, looking at in Zimbabwe, think of your typical well-to-do, wealthy person. They're usually overweight. They're probably going to be diabetic, high blood pressure, don't eat very well. So, those comorbidities are often what then contribute to excess mortality in those patients. If you look at the data globally, being diabetic, having high blood pressure, being overweight, those are risk factors for death and severe COVID. So it doesn't, you may be wealthy, you may be well-to-do, but your body might not be able to fight this. And the ventilator doesn't cure COVID, it doesn't treat COVID, it buys you time and takes the work of breathing off your body for long enough until you recover. But if you recover. Yes, but if your body can't make that recovery, doesn't matter how great a ventilator it is, doesn't matter how clever and how smart your doctor is and how expensive the facility is, often there's only so much we can do.
Lifestyle.
But besides that, every vaccine to do with COVID-19, disease is going to be offered free to every Zimbabwean.
Good.
So no one is going to make a single cent out of the COVID-19. This is why we are saying even if you go and buy, you buy them through government. They will be kept at the central government stores, the cold chain.
Right.
And when you say, I have got my workers whom I want vaccinated, we say fine. We'll give you the staff from the Ministry of Health. Who will make sure that you have taken 10 doses. They have been applied for they will be there. And we are the only ones who will give the certificate.
The COVAX facility from the WHO is set to make its way to Zimbabwe, a donation of just over 1 million COVID-19 vaccines. This will add to China's donations to date of 400,000 Sinopharm vaccines. Like any novel virus, they are constant discoveries and developments. So let's not be too hard on our scientists, on our doctors, on ourselves. Everything to do with COVID-19 is happening in real time, so give it time. We cannot have all the answers just yet. And remember, Dr. Google is not a certified health professional. A jack of all trades is a master of none. So let's keep probing these discussions and fully equip ourselves with information so we make the best possible decisions to protect the human race, our fellow countrymen, and our loved ones, and ourselves.
A lot of stuff on social media at the moment. Very concerned that we're vaccinating during a pandemic because the vaccines were not designed for that. I mean, we vaccinated 15,000 cabin crew when I worked for Emirates. And they were all vaccinated when they were well.
Was this for SARS?
No. This was for yellow fever, hepatitis B, typhoid.
Okay.
They travel extensively, so they're vaccinated extensively. And you're vaccinating them when they're well before they're exposed. What we're doing now is we're vaccinating people when they're sick. Or when there's a lot of virus around.
Well, what were we meant to do? You can't vaccinate for something you didn't know was coming. Yeah.
Exactly. But we need to suppress the virus before we vaccinate. Because the danger is that you're starting to produce antibodies when there's virus everywhere. And if you do that, the virus will escape. Because it goes, we've just produced 8 copies and one of them's resistant to the vaccine. So the ones that are resistant to the vaccine get suppressed and the mutant evolves. And then we could be facing multiple mutants because we're giving lots of different kinds of vaccines. So the ideal would be to suppress the virus right down. There's some interesting graphs and Henry's seen them. And they basically show the virus coming down very precipitously after the permanent secretary allowed us to use ivermectin, and that was the 26th of Jan. 25th of Jan, we had 70 deaths a day. 26th of February, we had none. For the first time, we hit 0. And what I recommend to my patients, and that is go to your GP, get a script for ivermectin, take 12 milligrams every 2 weeks. If you're heavily exposed, so you drive Auntie Ethel to the hospital and she's very sick, then speak to your GP about upping your dose for a little while. But take ivermectin because it buys you time. There is no point in vaccinating dead people. Okay, well you can, but I can't really see the point. So let's keep everyone alive until they're vaccinated.
But I'm scared now because I've Googled and then my WhatsApp group told me that ivermectin was made for horses and animals and not for human beings.
Okay. I love it when they say ivermectin's an animal medication because at the risk of stating the obvious, we belong to the animal kingdom. We're mammals, okay? Ivermectin is a medication designed for mammals. Right. It's been used in humans since 1988. Okay, it is a WHO award-winning, or it's an essential WHO medicine. It won the Nobel Prize because of its safety and what it's done for humanity in 2015. To give you an idea, there have been 16 deaths from ivermectin since 1988. That's 16 deaths in 32 years. 1 death every 2 years. As of the 14th of February, there were 728 deaths from vaccines.
Your position on ivermectin?
Well, that's a new drug.
Yeah.
New in terms of people wanting to bring it on for COVID-19, but it has always been there for parasites and so on. Right. And here in Zimbabwe, it has always been here registered for use in dogs. And so it was available, being used for the dogs, you name it, and so on. So when the debate started coming in, people were confusing 2 issues here. We were saying, please don't go take ivermectin for dogs and use it in human beings. That is just so unethical. And we were really concerned by any doctor who was promoting that. And we said, no, we can't have that. We were saying there's ivermectin for humans out there. It has not been registered in Zimbabwe. This is where the Medicines Control Authority of Zimbabwe came on board to say, look, if there are doctors out there who want to use ivermectin for people, for humans, it must come in properly, get through the regulatory processes, get registered, and then if you're going to use it, because this is a new drug for a new disease, you must follow the right things that you're supposed to do in terms of monitoring, in terms of documentation, so that at the end of the day, we're able to decide and assess, is this scientifically good or not?
So silver has been discredited. Unfortunately, there is clear evidence that it may do harm to the lungs and that it doesn't really dramatically reduce your risk of either infecting or transmitting COVID-19. So I think the silver 19 is definitively a no, at least based on the science right now.
Yeah. Okay. And in terms of preparation, I mean, it's not nice to prepare for doom, but should people still be getting oxygen tanks and keeping them at home if they know that they're living with someone with a pre-existing condition, comorbidities? Should we do all of that, or is that just dramatic and panicky?
Here's what happens. If you get a smattering of infections day to day, I think the system can cope with that. If you wind up in a situation like we're in January, where you've got hundreds of people infected at the same time, then the potential for shortages dramatically escalates.
It was high, it was serious.
And it was for a very short period. I mean, it was probably 4 weeks of absolute chaos. Then afterwards, you suddenly have a bit of a calmness. So I would say that the things that have helped, a lot of the private insurers have come to the party. They are covering for hospitalization for COVID. They are providing home care as well, which is covered through the insurance. So I'm hoping that the need for families to fork out their life savings to provide for COVID sufferers will be substantially less. But I think as a nation, we still have a lot of obligation to try and increase our capacity for care. I don't think it should be up to families. I think collectively the nation must do more to provide treatment capacity for the sick when they do fall ill.
Right. Lucius, what do you know about the COVID-19 vaccine? Sandozvo zvamuda kunyatsonzwisisa hamuna kunyatsobatiswa ipapo.
Iyo yatinoti vaccine inzira yekudzivirira chirwere. Zvatinoita unobayiwa kajekiseni kanenge kane either chakada kufanana nevaccine iroro kuti vaccine yacho raurayiwa risina virus yacho raurayiwa risina simba, asi zvokuti mwiri wako ukasangana nacho unenge wadzidziswa kuti chirwere ichi ndo zvachakaita. Mwiri wako watogadzira masoja ekuti ukazosangana nacho chinhu ichi unorwisa chirwere chacho kuti usazorwara nechirwere chisazokukurira. Ndo mashandiro evaccine.
Well, you touched on it, the vaccine itself. I think there's so much misinformation about the vaccine, from those who tell you it doesn't work, from those who say it's going to change your DNA, from those who say all sorts of things, and it's really frustrating because at the point where we are now, we would like everyone to take it because this is the additional preventative measure. We've been doing all those other things which are really very important, and we must continue with those as well. But where we are now, after we went through the first wave, the second wave, and we can see how deadly it can be, it is so important to add on that additional measure, and that is the vaccine.
Now there's that perception that COVID is in the affluent areas, and that it's not in other parts of the country. Chimbotudza chokwadi kuti zviri kufamba sei, COVID iriko here kwese kana kuti sure in some areas it's still
COVID is everywhere. I think to be honest, when you see the statistics that Ministry of Health issues every single day, they also tell us, they have a table which shows you per province and so on, and if you dive further down into the data, clearly shows you that this disease is everywhere. It's not just in the urban areas, it's in the rural areas, it's everywhere. And so it just depends on how people then manage it, how people are behaving. Some people might be in crowded places and they're not managing their hygiene and so on as well as they should. Others might be, the rural might have more fresh air. But COVID-19 is here throughout the country. It's not in one place.
But to those statistics that we do receive from the ministry daily, the question then is, are they accurate? Because are we testing enough? Those areas that indicate lower COVID cases, so how do you then know? It's not like we're going to Nyaradzo Funeral Services and saying, you understand? Because there's so many people that are being buried, especially in those areas, where you'll never know Chaitika. Did you get me? So isn't there that sort of, that there's a gap somewhere?
I think there's always a bit of a challenge because this is a pandemic. It starts an epidemic. And when you're in the middle of it, there is no way, even big scientists globally will tell you that there's no way you will have all the numbers that you want on that particular day. Because as we're speaking now, as I'm calculating, adding them up, someone is contracting it and they haven't been included. Then tomorrow you find out, oh, that person had it, but they were not on our books at that time. And that is just normal. The idea is to send the right message in terms of how transmissible that disease is, what people need to do, what we should do together. We also commissioned what we call a national prevalence survey, which is going to tell us exactly what the situation is like on the ground. But believe you me, it really doesn't matter what it will say, because the interventions that we need to implement will remain the same. So let's just do that. Let's do that.
Ivermectin or not, vaccination or not, conspiracy or not, third wave or not, either way, wash your hands, sanitize, maintain social distancing, maintain physical distancing. This is the correct way up to wear your mask. There's white boning on the top to protect you. Clip it on and clip it in.